Today on Shadow Me Next, we're diving into a story that challenges so much of what we assume about medicine, expertise, and the limits of what's possible. I am pleased to welcome Dr. Aaron Hartman, a triple board certified physician in functional, integrative, holistic, family, and regenerative medicine. But the thing that stands out most about him isn't his credentials, it's the way he thinks and the courage that one little girl named Anna gave him to rethink medicine entirely. You'll hear how his path was pretty traditional at first: medical school, residency, military medicine, private practice, and then one moment with one patient, a little girl that he and his wife brought into their home, changed everything he thought he knew about standard of care. That moment pushed him into a decade-long search for answers the system wasn't offering, and opened a door into functional and integrative medicine he never expected to walk through. What I love about this conversation is how honest he is about the limits of expertise, the blind spots in evidence-based medicine, and the importance of staying curious, even when your training tells you to stop asking questions. And he brings so much clarity to what it actually looks like to build a meaningful, flexible, ever-evolving career in medicine, one that grows like you do. This is a powerful episode for anyone who's ever felt that internal nudge that says, there's more here. I'm supposed to go deeper. This is Shadow Me Next with Dr. Aaron Hartman. Dr. Hartman, thank you so much for joining us today on Shadow Me Next. You are triple board certified in functional medicine, integrative and holistic medicine, family medicine, and anti-aging regenerative medicine. There's so many titles, and the amazing thing is, I think your journey goes well beyond those titles. So I cannot wait to talk to you about this.
So I'm excited to be here and share stuff with your community and take a deep dive.
Yeah, a deep dive for sure. And you are also an associate clinical professor of medicine. So, you have a lot of knowledge when it comes to talking to not just patients, not just, the average Joe, but also students interested in medicine as well. So we're going to approach this kind of from all angles today. But let's go back. Did you always know you wanted to be a doctor? That's always a fun question.
You know what? It's funny. I remember being maybe in second or third grade, walking through the park with my parents, saying I want to be a doctor. I was going to do this, that. And at that stage, parents were like, "Yeah, that's cute." I remember, I grew up in Harrisonburg, which is a small town in the mountains, the valley in Shenandoah Valley in Virginia, and our family doctor was a country doctor, and you go to drive out of the city, the massive city of 20,000 people, right, and go to his little office, and he talked to my mom, listened to her lungs, and then give us some pills. And I remember as a kid being like, I can do that. That seems pretty easy. So that was kind of where I realized I want to be a doctor, because I'm like, well, it looks pretty easy. Talks to my mom, helps us out, you know. And at super simple beginning, but that's kind of how it started.
I love that. And I think that we'll learn throughout our conversation that obviously you achieved that, but then it took a major shift. And again, it was from personal experience, and we'll definitely talk about that. But tell us about your medical education journey. So you graduate high school, you go to college. What does it look like after that?
I was very focused. The purpose of high school was to go to college. I mean, ultimately, it was to become a physician. So, like most students, went to Virginia Commonwealth University and graduated summa cum laude. From there, very focused, had a scholarship. So I was fortunate to get out of college with no debt. And then I was like, what's next? And go to medical school. And again, I was kind of raised no debt. So I got a Air Force scholarship and went into the Medical College of Virginia, and then did my residency there as well. Because those of your listeners who go to do residency, I mean, you don't really have a life. And so I realized that, MCV was great, great reputation, great clinical experience. And so I had a social network, so I stayed local. And they actually had a pretty difficult internship. Their internship year was a medical surge internship, which was 100% hospital based.
Mhm.
So it's like it was one step below a surgery internship is difficulty, but harder than internal medicine. So you learn a lot in a year. And then did my about the additional 2 years in family medicine, and then did the military for 4 years. And military was awesome because every 6 months my job changed. So I got deployed overseas, helped run a clinic in Germany, Came back, ran a clinic in MacDill Air Force Base, realized there was no one doing dermatology on the base. So
Hmm.
did start doing some dermatology training at USF and ended up running the dermatology through our clinic there. They didn't have anybody doing stress testing, so I picked that up as well. And my thing was always to learn a new procedure every year. Got out, came back to Virginia, joined a private practice, and this might resonate with some of your people. Like that was back before it was uncool for doctors to advertise. And so I realized for our practice to grow, I set up the first website in 2007, which was like a one-page sheet. And that was before other businesses started buying, like Health Grade started buying websites. So we were actually ahead of that. So now if you come to the local community and you're an individual, you won't be able to make web presence because it's owned by different organizations, which is another topic. And then built that practice up to 10 practitioners. The busiest that practice was, we were seeing like 60,000 people a year come through it. So it was busier than the area across the street.
Whoa.
During that, I decided to start a research company. So I started Virginia Research Center, and we ended up running over 70 clinical trials through the center over 12 years. And then started studying functional medicine, integrative medicine. And somewhere in that whole mess, I decided to get a seminary degree as well. So when I was in the military, I went to seminary, and it took me 7 years to finish that because it was a part-time gig. So it took longer than usual. But just, if you learn something new every year and the doors open, you walk through them, and you do that for 25 years, and you look back, you're like, wow, like, where's everybody else? And this is cool. And that's been kind of my journey.
It's incredible. And I'm so glad that you have had this experience that you can share because I think there is this common misconception right now that if you want to become a physician, MD, DO, if you want to become a physician, you're going to be pigeonholed for the rest of your life. I talk to so many PA students and they say, or pre PA students, and they say, well, Ashley, I want to be a PA because I want job flexibility and I don't know if I want to stay working in the same field for my whole life. And I think, unfortunately for you, you're going to have to revisit that thought because that is not true. And Dr. Hartman, you're living proof of this. I mean, you've had a very varied career when it comes to your career in medicine. Do you think I mean, is that normal? Is this something that you've obviously had to work really hard to seek out?
My philosophy was to walk through doors as they open. I'm not like a go-getter, like I'm gonna like run like I remember saying I'm never gonna do research, I'm never gonna write a book, I'm never gonna own my own business, like because I don't want to do that stuff. I just want to be a doctor and help people and travel and have fun and all that kind of stuff. But if opportunities show themselves, you take them. If it's not hard, it's probably not worth doing. So you need to do
Mhm.
hard things, and it's amazing. There's this thing called the 80-20 rule, the Pareto rule, and it's basically the idea is 20% people do 80% of the work. And that include or the 20% of the people have 80% of the knowledge, or however you want to frame it. The ratios change based on what you're looking at, but it's roughly true.
Mhm.
So all of a sudden with doctors, 80% of people are following the herd or doing the status quo. And 20% will do things a little different. And then it's the 20% of the 20% of the 20%, which is the 1%. And those are the innovators. Those are people who are thinking outside the box. And so you have to go from this 20% to that 20%, to that 20%, realizing that by the time you get there, you're going to look around and it's going to be like you'll be alone. But a lot of people will be looking to you. And
Right.
so it's one of those things that you have to be willing to do hard things. You have to keep on learning. But I think just realizing that a pre-PA student, a pre-med, whatever the level is, you know, just be open to new things, be willing to do hard things, be curious, be curious. Um, be the first one there, the last one to go home. I did more when I was doing my OBGYN, did more deliveries, did more fetal scalp electrodes. When I was doing my ICU, I did more intubations because I was first one there last. I wasn't the smartest. I wasn't the person with photographic memory who could quote stuff, but I just worked hard, and that's worth a lot more than being the smart person in the room. And so just be willing to do hard things, be curious, don't stop working, and you'll be amazed by where it takes you.
Be curious. I love that. I think that's fantastic, especially nowadays in a world where, we're able to just search up information immediately in our hand or online right there. It's all instant. The curiosity factor is fading. And I think if we maintain that, like you said, doors are going to just start flying open and we're going to have to walk through. Dr. Hartman, let's talk about this. I'm very, very excited to talk about this. So many guests on the show, like you just did, share a personal experience that led them to medicine, right? In your case, a personal experience actually opened your eyes to the realities of medicine, the realities of your profession. And I think it took you on a pretty big pivot. Can you tell us a little bit about this?
So this was during my going my fourth year at MacDill Air Force Base while I was in the Air Force. I was a captain turning a major at that point in time. And my wife, who is a pediatric occupational therapist who worked with kids with special needs, so she had all these rare cases. We have interesting conversations about the things I heard about in textbooks that she was seeing every day in the clinic and where she was
Oh.
working. One of the little girls, Anna, her foster home was closing. She was 12 months old, and she asked me if we'd be willing to foster her, bring her in. And I said, sure, because of my personal belief system, part of that is to take care of the vulnerable, take care of people who can't take care of themselves. And I'm like, I
Mhm.
say I believe these things, I should be willing to do that. So for me, it was very mechanical, to be honest with you. But in the process, I did fall in love with Anna, and we started the whole adoption process. And what happened was really interesting. She was failure to thrive. Her birth mother did crystal meth the entire pregnancy. She had a stroke before she was born. She was born in a drug coma, and usually kids are there for about six or so. She didn't interact with the world for 6 months, and she was small. She was less than fifth percentile. So the GI doctor was like, "Hey, she's not growing. Let's put a tube in her because that's standard of care. Cut a hole, put formula in." And my wife and I had conversations about speech development, about crawling, about neurological development. Chewing and swallowing changes facial structure development. I mean, you have more, if you don't chew and swallow, it can set you up for sleep apnea in adulthood, for example, right? So all of a sudden, it's like, no, we're not doing that. Like we have high hopes and dreams. We have aspirations, like all parents do, or future parents do. So we said no to the tube, and we were reported to Child Protective Services
Oh my gosh.
for for child neglect. Yeah, because we refused to do what the doctor said. Now my wife, it's so funny because I'm a doctor, my wife's an OT, and we got investigated. The nurse who investigated us, my wife actually shared patients with, and so they kind of joked about it, like, aha, this doctor puts tubes in all the kids, and they kind of joked about it. And we had to like meet with the nutritionist. The nutritionist was like, yeah, you're doing the right stuff. So it went away, but that was my first inflection point. The system does not like it when you say no, when you
Hmm.
question the
Hmm.
system. And in the special needs world, with kids with special needs, this actually happens a lot where kids are actually taken away because they have rare diagnoses that the system doesn't understand. And the parents literally not just fighting for the kids, but they actually lose them and have to fight. It's horrible that this even is possible, but it does happen. And so I was kind of watching that from the outside, kind of sort of not quite from the inside. But here's the major inflection point. 6 months later, my industrious wife found a growth chart for kids with cerebral palsy, and Anna was in the middle. So the expert didn't know this existed. And so that was like the aha moment for me. Like the experts don't know. What else don't they know? What are the blind spots that people think to be true that's wrong? People know not to be true that's actually not true. And so it put a weight on my back because all of a sudden I realized I had to figure it out. I had to be the person who'd get up at 4 o'clock in the morning and pull up articles on nutritional therapies, gene-based cell therapies, things based on SNPs, which are small. They're basically typos in your genes and how that can affect. And so drug exposure, crystal meth, cerebral palsy. So that ended up being a 10 to 12-year journey of me getting up ridiculously early, reading articles, reading books, finding experts, traveling out of the country to meet these experts, and realize it's like it's like Alice in Wonderland, right? You go there and you go from black and white to a color world. And once you go there, you realize, oh
Wow.
my gosh, there is so much stuff out there that we're never told about, we're never taught about, that we ignore. We say is witchcraft hooey. It's actually cutting edge in Germany and Russia and Switzerland and China. And all of a sudden, that became my practice of medicine, is doing that stuff not just with my daughter, but with other people as well. And that is what led to me starting my practice, Richmond Integrative and Functional Medicine, so taking everything I'd learned with her and starting an entirely new practice with a entirely different economic basis. You have to make money, obviously, to practice medicine. And that's been a journey as well, figuring out the economics of actually enable me to practice the best medicine that I can learn in a system that says, one widget, $1. So that was another journey as well.
Incredible. That is an absolutely incredible story. And I can't wait to unpack some things in there. But before we talk about how your day looks a little bit different now from what you were doing to what you're doing now, you mentioned something that I think is really important that we touch on, and that's called standard of care or evidence-based medicine. And my two questions for you about this are, number one, what does that generally mean in the medical world? Like if you walked into a hospital and you hear people talking about standard of care, what does that mean? And then what does that mean to you? Because I have a feeling that it might perhaps be two separate things.
So standard of care is just the basic concept that whatever's done in the local community, and standard of care can be different in Mississippi versus New York versus California. It's basically an unstated consensus, like what's going on in your area that people do. Now, sometimes they become standardized, like when I did my OB/GYN training, they had the ACOG have a big book, and they actually every year put it out, and it's got like the protocols for absolutely everything. So they have their own
Mhm.
stated standard of care, and it's basic consensus. If you get a room full of experts, what's the consensus on diabetes treatment and management, post-concussive syndrome treatment, chronic fatigue, whatever it is? And so it's a consensus-based treatment. We're following a herd. Um, and so that's kind of what standard of care is. The issue with standard of care is that if you're outside of it, there's really no room for that. And there's so many things. People forget that, like with kids, up to 60% of medications used with pediatrics are not FDA approved. 30 to 40% of drug use in adults is not FDA approved. So it's like you get a drug out there like metformin or aspirin or Cozar, losartan, and you find out, hey, it lowers uric acid. You can use it for gout patients. It lowers TGF beta. It's an anti-inflammatory. Maybe that's part of how it helps blood pressure. You're right. And so all of a sudden now, medications get a wider, broader usage
Mhm.
that might fall outside the quote unquote standard of care, but that's kind of how the practice of medicine works. So it's consensus basically. And typically you have, room a bunch of smart people, and what can you agree on? The lowest common denominator. So it's not cutting edge care. It's okay, what can we all agree on? So that's something to think about. Evidence-based medicine is not what it used to be. It was supposed to be. There was an article that came out, it was either 89 or 91, I believe, in British Medical Journal, maybe, or JAMA. I forget which one, that actually defined evidence-based medicine. And it was three legs. It was up-to-date, accurate clinical evidence, so research articles, et cetera, patient preference, and clinician experience. So the fact that I've had over 100,000 patient encounters in 7 countries and 4 continents meant
Cool.
something, meant something.
Yeah.
I've taken care of malaria in Ecuador. I've taken care of diabetic wounds in Honduras. Like I've seen a flesh-eating disease in Morocco, North Africa. So it's like I have a toolkit that's a little unique, right?
Mhm.
The problem is now it means solely randomized, double-blind, placebo-controlled trials. So now when you room with experts, like what's the evidence for that? They mean what's the RTC? And then
Mhm.
people don't realize this whole thing about publication bias, where just like the standard of care, to get in a journal, an editorial board has to say, yes, we think that is true. Let's put it in. And this is a publication bias. And then, according to Dr. Ioannis and PLOS, which is the largest um, online journal in the world, 50% of all research findings are later found to be false. So all of a sudden, the evidence we're looking at, half of it's wrong. And when I was in medical school, I was told half of what I read in a textbook was wrong. So all of a sudden, we've gone to this technocratic practice based on research articles that, batting 500, maybe, batting 500 is great for baseball and horrible
Mhm.
for flying planes.
Yeah.
And so, I think, that's where I think we've kind of got off the rails a little bit with the evidence-based medicine thing. And evidence-based medicine ignores population data. It ignores meta-analysis. It ignores healing traditions. I could give you so many examples. One example, in ancient Ayurvedic medicine, they believed ghee could be used to treat neurological issues. When I first heard that, I'm like, ghee treating neuro, that's stupid. That's dumb. Well, fast forward, there's actually now a FDA-approved drug, phenylbutyrate, in combination with phosphatidylcholine, that's being used to treat symptoms of ALS. And what we
Whoa.
now know is that butyrate acts like a chaperone to clear out lipid debris in our bodies. Now, butyrate's made in your gut naturally by bacteria. So if you have a good diet, fiber, you actually make your own butyrate. But nature's best source of butyrate is clarified butter or ghee. So then it's like, how did people 4,000 years ago connect some dots to figure out what just now in the last 3 to 5 years evidence is showing there's evidence for that? And so that's where what I love what I do. It's a lot of times it's connecting those dots, sometimes 10, 20, 30 years before the evidence does, and then taking evidence that's published and accelerating it, right? Like using the PONS, it's a portable oral neurostimulation device that was used to treat kids with CP in Russia. It was available in Canada. So I went to Canada to get it, and it's only approved here in the United States to treat balance issues with MS. Oh, why are they using it in Russia and Canada? So sometimes this evidence-based journey is also kind of, you gotta look at all the evidence, all the data, and then use your clinical expertise to figure out, is this true or false? Because sometimes evidence says things that are false, and how are you gonna know the difference?
I'm blown away. I'm actually blown away right now. That is so interesting. Dr. Hartman, do you think so for functional medicine, do you have to be a medical doctor? Do you have to be an MD or a DO in order to enter functional? The reason I ask is because I'm imagining the fact that your view of this is so incredibly well-rounded because conventional medicine, you have that education there, but then you also have this functional medicine education as well. So what does every functional medicine doctor have the same background you do?
No, no, it just depends on how deep you go. And obviously I'm someone who goes pretty deep. I I think the basic principles are that with functional medicine, the foundations are foundational. You know, diet, exercise, sleep, meaningful relationships, nutrient deficiencies. Like if you do the basics, that hits 80% of everything. So you can have, nutritionists that are trained in functional medicine. You can have acupuncturists, chiropractors that are trained in it that can do the 80%, that can say, hey, you're eating processed foods. And oh, by the way, if you have post-concussive syndrome, omega-3 and healthy omega-6s can actually help your brain heal. Don't eat trans fats. Don't eat, rancid oils. Like that, you don't have to be a triple board certified clinical researcher doctor to give that kind of advice. So that's the beauty of functional medicine is that at the basic foundational level, it's really accessible. But then you get to the nuances, the weeds, where it's like, okay, you get past the 80% and you still have post-concussive syndrome or long COVID or post-Lyme, you got a tick illness or something else, the flu, and you've been feeling crappy and hurting for years. Well, then it's like, what's the literature say? And you can use low-dose naltrexone, which has been around forever, to remodulate microglia in your brain. Okay, cool.
Wow.
I use that with a lot of my autistic kids, my pandas kids, and it helps calm the inflammation down in your brain. A lot of all all chronic pain actually has a centralization process to it, and low-dose naltrexone works great for that. So all of a sudden, as a medical doctor in this training, I can actually take some of that data and translate it. With my daughter, for example, she had really bad tone in her legs. And the standard of care for her at DuPont, which is one of the top pediatric places in the world, was to put a baclofen pump in her back, to put baclofen into her spine. Locally here, it was to do spinal surgery, cut her hamstrings, or send her to Texas for a selective dorsal rhizotomy, super fancy test. They cut little nerves to release the tone. That was the cutting edge stuff. But then I knew from functional neurology studies that you can remodulate the brain with peripheral nerve stimulation. And I was looking for a neuromuscular stimulation device, and I found one called Revitive, FDA approved, by the way, to treat circulation issues in the legs. And within 6 months, her tone in her lower extremities was gone.
Wow.
And so she went
Wild.
from hunching over. So that $300 device probably saved a $400,000 procedure. And when you realize this happens all the time, when we talk about electrical stimulation, there are devices FDA approved to treat migraines, hitting your V1 part of your trigeminal. There are ones used for treating different pain syndromes, muscle spasms. Professional athletes use this to help build muscle mass. And the question is, how can I translate these data points to this chronic fatigue fibro? There's actually an interesting device called Quell, Quell, and it actually activates and this might be getting a little nerdy here, but hopefully your people get this here.
We can nerd
Act,
out.
okay, it activates your peripheral alpha fibers, which go into your rubospinal, the red tract in your brain. The way your brain works in the midbrain, it actually sends inhibition down to inhibit pain. When that gets dysregulated, now shingles, my arm hurts, a phantom limb syndrome, the arm that's not there hurts. Well, this device actually helps remodulate that. And I've had patients with peripheral neuropathy and chronic fibro pain have it go away over 3 to 4 months with a little buzzy thing that buzzes your leg for 12 hours a day. So part of what I do is take these data points that there's data here, data here, and data here, and then fill the gaps in. And that's unfortunately where a lot of our conventional stuff doesn't do, is that we'll take this data point for the physiatrist and this data point for the neurologist, migraine person, but it won't connect those dots and fill in the gaps for your typical average person that I see in my clinic.
That is so cool. And actually, it leads really nicely into my next question. So, in your opinion, how has your day in clinic, for example, how has that changed from when you were practicing conventional medicine to what you're practicing now? You're describing a little bit of it, but really getting down to nitty-gritty specifics. Is it vastly different for you? Is it vastly different for your relationship with your patients?
So my day used to be when I was in the heat of it, when I was seeing my busiest year, I saw just slightly below 6,000 patients in a year. So for those people out there, that's a lot of people. I was getting to the hospital. I think the standard physician sees maybe 4,500 is considered a lot, right? So I got to the hospital at 6 o'clock in the morning. I did rounds on my admissions overnight, followed up my existing patients. Would then go to the clinic at 8, 8 till 5 in the clinic, seeing people, hospital follow-ups. If you need to go back to the hospital, see someone in the ICU, I either go during lunch break or at the end of the day. I typically get back home about 6 o'clock, and I did that 5 days a week. And then every fourth weekend, I was on call, so I was working through the weekend. And every Tuesday night, I was on call, so I did it 8 to 8. So
Oof.
so I did that for from 2007 till about 22. So that's a standard good old fashioned family medicine kind of practice, right? On top of that, I was doing my reading and research, and actually in 2016 is when I started my functional practice. So I was doing that as well at that time. What's it look like now? Now at that point in time, I was also getting up at 4 o'clock in the morning to read this stuff. Now I get up at 6:30 in the morning, um, have my coffee, read a little bit, go to the gym. Clinic starts at 8:30. I go 8:30 to 12. I have a 2 hour break between 12 and 2, and then see patients from 2 to 4. So, a pretty light, not big, busy day. I have Wednesdays and Fridays off for admin time. So that's when I research my patients now. I'm not stealing from my sleep anymore because sleep is the super drug.
Yes.
And so when I was young, I was told and believed that I'll sleep when I die. Now that I'm older and know more, I'm like, not sleeping will kill me. So increased my risk for cancer and diabetes and all kinds of stuff. Don't listen to that residents out there. You gotta work hard. You gotta not sleep. But um, it's just totally different now. I used to take my patient empanelment at one point in time was right at 2,800 patients. Now it's 300. An intake for me is 2 hours.
Wow.
So I was doing intake 2 hours, order a bunch of fancy labs, et cetera. Follow-up is an hour and 15 minutes, and a routine visit is 45 minutes.
Mm.
So instead of being 10 to 12 minutes, I have 45 minutes routinely with a patient. Sometimes shorter, sometimes they're really short, it's 30 minutes. So it's vastly different, but it's interesting. I have patients I've been working with for years, and I did this in primary care because I was attentive and I listen to people and you see them a lot, but you get to know people's story a lot better. And I can give you a story about my wife, actually. It's funny what you learn. She was an OT, and
Mhm.
she developed really bad anxiety in grad school, almost dropped out, got anxious, depressed, just felt super off. Ended up graduating, got straight A's, like all of the years in grad school, did well. When I met her, I was kind of like, I remember hearing her story and be like, suck it up. Like, that's just what we do. We work hard. She's ended up developing a couple of health issues, mast cell issues, chronic fatigue, fibro, had really bad chronic fatigue for 5 years. Da, da, da. 15 years into our marriage because I'm a very attentive husband. Um, I'm glad you're laughing, not scowling. Um, Realized her trigger for this health crisis was anatomy lab in grad school where she was exposed to formaldehyde for 6 months straight.
Whoa.
Formaldehyde is a neurotoxin. It binds to your proteins and changes the conformation. That's how it preserves stuff. Um, and it took me 15 years to figure that out, but part of the functional medicine thing is realizing how the environment affects our health. So that one data point led to her health issues for 15 plus years. And that was just one thing that my this alternative medicine, functional medicine, has helped me realize that environment is just as important as the food you eat. It's just as important as the people you're around, just as important the medications you do and don't take. Um, I'm going to say something that you didn't ask me to say, but just one data point that can help your listeners. 30% of all pharmaceuticals, there's actually a textbook on this that I read through. 30% of all pharmaceutical drugs are mitochondrial toxicants.
Whoa.
Just think about that. And half of all drugs are actually detoxified or processed out of our bodies by our gut microbiome. So it's two basic functional medicine foundational things: the idea of mitochondrial toxicity and gut microbiome that comes together with traditional medicine is ignored by the system, a blind spot, if you will.
Wow. Again, mind blown. Like it's like fireworks over here. Like the one thing and then the next. That is, I'm glad you mentioned some of these things because you have a blog that we can find on aaronhartmanmd.com amongst a bunch of other things that we're going to talk about in a second. And you dive into some of these things that people might not know about. Formaldehyde, obviously we know not to drink it, but we didn't really know what else we need not to do with it. Mold, you talk a lot about mold and some of the things maybe people need to start thinking about. That can be found in your blog, which we're going to talk about in a second. But as our last question before we wrap up, especially as a parent physician, you've refused to accept that's just how it is. You know, that phrase, that's just how it is. But that's unacceptable to you as an answer. If patients or clinicians are feeling this way right now, with their own health challenges or with the health challenges in their patients, what should their next step be?
You need to research. Don't give up. Don't accept the status quo. Answers will, if you look for the answers, you will find them. Or sometimes they actually, if they find you, to be honest with you, it's don't give up. And so I actually was on a podcast with an ultra marathon runner in New Zealand who
Wow.
like was the first woman to like run 150 miles in some random desert somewhere. So like super motivated, super mindset oriented, not a doctor, not a clinician, just a super athlete. And her mother had a stroke, and her mother later got lymphoma. And her mother's still alive now. She should have been dead 15 years ago. And she did not accept what New Zealand told her, that we can't help your mom's stroke. Figured out about hyperbaric medicine, got a hyperbaric chamber, figured out peptides. And her mom, within 3 years, 100% recovered from her stroke she should have passed away from.
Wow.
5 years later, they had lesions in her brain. They actually happened to be an intracranial lymphoma. Again, she figured out some stuff, hyperbaric, ketogenic diets. It's a lot of interesting literature on cancer is a metabolic disease. There's a whole book on it. And so she found this information, and her mom's 15 years into it, thriving, doing well. And this was someone who's not medical. So part of her story that was just impactful to me is you might feel like, how do you do this? You can do it too. And so I wouldn't give up. And the reality is just research, find stuff. It's amazing. One path leads to another. I started my functional medicine training, and then one of the lecturers was Datis Karazian, probably the top functional neurologist in the world, him and Dr. Brock. And I spent a year studying functional neurology, which is how you can look at a patient, how they walk and figure out which part of the brain's messed up, and then how you can actually get the brain to self-heal repair using physical and electrical modalities. The whole field of medicine out there. And so once you start looking at things, you'll find you've got microbiome stuff, hormones, environmental toxins. I have a textbook of clinical environmental medicine sitting right there. It's a book about how the environment can affect your health. And so when you find those things, get your library together and put them in your books to read. It might not be anytime soon because you're in school or whatnot, but start collecting the books you want to read, and it's amazing. One thing leads to another, leads to another. Unfortunately, in our board certification, siloed training world, we take the inquisitiveness and the curiosity of students, and we kind of like eliminate it when you finish.
Mm-hmm.
I remember, you'll appreciate this. I remember the last semester of my residency training, my first one, talking to my cousin. I read all the textbooks. I got like 97th percentile on my board cert. So it's like I was a top 3 percentile. I remember saying to him, I've learned everything. I've mastered medicine. And he looked at me and was like, Hartman, like, what's your no? And and I remember thinking, you just don't know, young lad, how smart and brilliant I am. And in hindsight, I was an idiot. Like now I'm like, I tell people, Ashley, I don't know what I'm doing. Like I'm still practicing. I'm still figuring stuff out. And so it's interesting how the system kind of beats that out of us. Don't let it beat it out of you. Stay curious. Keep learning. Never ever give up on yourself or your loved ones, because the system will.
That's so true. Dr. Aaron Hartman of aaronhartmanmd.com. We mentioned your blog on there. There's a whole bunch of awesome, really, really awesome things. Your podcast, which is Made for Health, definitely check it out. Links to your YouTube videos are there. And then your book, Uncurable, From Hopeless Diagnosis to Defying All Odds. And that's uncurable. And this is going to be a great next step if this conversation is really resonating with you right now. It's an amazing book. It's available on his website. It's also available on Amazon. Please check it out. Dr. Hartman, it has been the most fun talking to you today. Thank you so much.
So I appreciate, and hopefully this was helpful to your audience.